Welcome back to the Groundless Ground podcast, the leading edge of mental health. I'm your host, Lisa Dale Miller. Remember, you can now subscribe to and download the Groundless Ground on your favorite podcast app or listen on YouTube, Spotify, and TuneIn. You are about to hear an in-depth dialogue with Kathy L Kain on understanding and working somatically and psychotherapeutically with patients suffering the effects of developmental and complex trauma. Kathy has co-authored with Steve Terrell a groundbreaking new book on this subject titled Nurturing Resilience. Kathy has been practicing and teaching bodywork and trauma recovery for 37 years. She is a senior trainer in the Somatic Experiencing Trauma Resolution model and an expert in integrating touch into the practice of psychotherapy and trauma recovery. She teaches therapists about the physiology of traumatic stress through her popular program, Touch Skills Training for Trauma Therapists, and is the principal author of Orthobionomy, a practical manual of somatic psychotherapy. Kathy, it is such an honor to have you as a guest on the Groundless Ground podcast. I'm so excited.
I'm happy to be participating. It's great. I'm looking forward to it.
So you've been teaching psychotherapists about the physiology of traumatic stress and developmental trauma for many years and aiding in their efforts to integrate and apply touch with traditional psychotherapy. My patients have benefited enormously from the trainings I've done with you. Before we launch into dialogue about your groundbreaking new book, Nurturing Resilience, can you tell us a little bit about your background and how you ended up specializing in creating a bridge between somatics and psychotherapy?
I started that at the very beginning. Part of that journey was actually in Australia. I was on the faculty in a somatic psychology program where my job was to teach the students about the integration of touch, because the whole program was a body focus, was really integrating the use of touch. Because I started my career as a body worker. And so I already was beginning this bridging process separate from anything to do with trauma. It was my job to help them understand how they could ethically and comfortably and with good skillfulness integrate a more specific body focus and the use of touch into their psychotherapy practices. While I was doing that, I was also teaching in the bodywork community, teaching body workers how to do their jobs. And one of the things that happens when you're traveling to teach is that you become the expert from out of town, whether that's true or not. And so in the bodywork world, one of the common things to do is to bring the client in for the other more experienced practitioner to work with while the client's practitioner is sitting and observing. So it's kind of our version of doing supervision consultation. And of course, who are the people that folks struggle with, but the most complicated clients? And what I hadn't really named yet for myself at that point is that the most complicated clients are often people who have trauma in their background. And that's one of the reasons why the normal interventions, whether you're a psychotherapist or a body worker, medical practitioner, why the normal interventions are having unusual responses, paradoxical responses, or they're not working the way you think they should work. Kind of accidentally, I became a bit of a specialist in difficult clients for body workers while I was simultaneously teaching psychotherapists how to integrate touch. And then those worlds started meeting. The psychotherapists that I was teaching were having the same kinds of experiences, just not from that physical bodywork perspective, but they were having the same struggles about the clients they weren't having success with. I already knew Peter Levine from him having taken some workshops with me, and we connected at that body level information because it's somatic experiencing. So he had that body focus in his work with trauma already. That was where we really kind of recognized each other's work. And he kept saying, you need to come in and take this training, and I'd like you to teach my students. And then that final piece got added in of understanding trauma physiology. I had experience in talking to psychotherapists about how they might consider the soma, the body, inclusion potentially of touch. I felt like I'd already figured a lot out just by on-the-job training. The normal things that I know aren't working with this client. How can I get creative about doing something different? Who can I talk to get some advice about this? And I've always been really lucky with having other professionals be helpful to me, from psychiatrists and doctors and experienced psychotherapists Chinese medicine practitioners to say, well, we would think about this difficulty with the client from this perspective. Once all those things were in the same place of trauma, body orientation, and knowing how to talk to psychotherapists about it, that just became the path. I felt like I had the language. It was my client population. My norm was working with the most challenging clients. So my home practice also became a practice of working with clients that people were struggling with. Pretty soon then I had this whole practice made up of people who had trauma in their background, very commonly developmental trauma. They're coming to me because they have physical symptoms. In consultation with psychotherapists, I started seeing their clients have these physical symptoms that the psychotherapist kind of thinks isn't their job, but it's making the situation more complex because the physical symptoms are made worse by some of the psychological interventions that might be happening. These clients often are people who struggle to get good help. First of all, sometimes they scare even really seasoned practitioners. Their symptoms can be really big and confusing. They have responses that are unexpected. And so even very experienced practitioners sometimes don't quite know what to do with that. These are the kind of clients that get referred on and on and on and on for that reason. I could step in and provide some help to folks who would want to be able to serve clients like this, but they need a little bit more information. In that process, I met Steve Terrell, who also was doing a workshop with me about the integration of touch into his practice. And then as I did with Peter, we noticed that we had some common ground. He was working with a different population of primarily at that time with children. He works more with adults now than he did before. And I was primarily working with adults. We realized as I was seeing the grown-up version of the kids that he was working with, and then we really started feeling like this is necessary information. So that's how I came to it. It was like a sideways thing. It's always been a little odd to me that as a body worker, the thing I'm known for is teaching psychotherapists. My focus in terms of teaching to psychotherapists has been to shorten the learning curve. It's been a long learning curve for me. I've been doing this almost 40 years. If we can shorten that down by getting all of this information that came to me from all these different sort of lineages, so to speak, into one place, it's going to just be quicker for therapists to kind of jump over a bunch of that wrestling that I had to do to figure it out.
I definitely can affirm that that's the case. Mental health professionals listening to this podcast right now who are thinking, I could never or would never touch my patient. So they have a frame for the dialogue we're about to have. Can you tell us why therapeutic awareness of body responses and the somatic skill set of working with them is so important for the successful treatment of trauma symptomatology? And I'm not just talking developmental. Impact trauma, complex trauma, PTSD, as well as developmental.
I'm actually not presuming that people will include touch necessarily. I invite people, if they do workshops with me, to practice touch because what I know from just many, many years of doing it, it's going to increase their capacity for observation. They're going to know more about what is happening in their client's physiology, in their somatic self, so to speak, by sitting across the room and observing that when they've had their hands on somebody in a learning environment, because now they've had a way to kind of compare notes, so to speak. So I'm not necessarily assuming that people want to or can incorporate touch. We had someone who came to one of the programs who was a prison psychologist. He's not going to be touching his clients, but he did tell them he was doing the training and was asking for feedback. And he consistently heard from them that they felt that he understood them better as a result of having had that training experience. And they felt more recognized and they felt like his interventions were more precise. And actually, some of the touch research reflects that. Psychotherapists who incorporate touch into their practice, very commonly their clients have the experience that really the same interventions that the therapists are reporting. I'm doing basically the same stuff as I do with the clients I'm not touching. The clients receiving touch are experiencing those interventions as being more effective, and they're experiencing being seen more by the psychotherapists. There are some arguments in favor of actually incorporating touch. But for me, it's really more about incorporating the body because our care delivery system, our cultural norm has split the psyche from the soma. I feel like that's actually a wound in our culture that we need to heal. And by bringing them back together in whatever umbrella, in this case, we're talking about somatic psychotherapy so that we're including the body as we're considering the psyche, is a healing of that split and that wound that our culture holds. It puts practitioners in a bind. I belong in the physical care world. I'm not allowed to treat the psyche, and yet I have to in some way if I'm touching into traumatic experiences. Trauma doesn't divide. We know that from the adverse childhood experience study. Trauma affects the physical self potently. We really know now that we can't separate physical symptoms from psychological symptoms. We are in how we demand treatment. And so we put this pressure on each of these categories of practitioners. Someone who's in the mental health field is supposed to just work with the psyche, but you can't, because there you're sitting opposite your client who has a pain syndrome, that has anxiety that manifests then in physical symptoms, heart issues. They might be cutting themselves as a way to manage their feeling of being out of control or their stress responses. And now they have this physical interface that's happening with the way they're managing their symptoms. We're pretending that we can do this separately, and it's not true. So for me, it's really just acknowledging the truthfulness of the fact that the psyche and the soma are not actually separate. Whether we're talking about developmental trauma or we're talking about later trauma, we have accumulating research now when there's been physical injury in the course of a traumatizing event, like a motor vehicle accident, or the differences, for example, between one hostage has been injured in the hostage taking or in the holding of the hostage versus someone who hasn't. The person who's been injured is much more likely to develop PTSD than the person who hasn't. So we know there's a correlation between physicality of trauma and symptoms that we divide up and say these are psychological symptoms. But how does that happen then if the physical injury makes you more prone to those symptoms? So for me, it's backing up and just saying we've made an incorrect division here to say that we shouldn't be working with the person as a whole, and they're going to manifest their symptoms. Some people primarily somatically, some people primarily psychologically or emotionally, and others, unfortunately, both. That's why we need to alter our delivery of care.
We'll talk more about how to do this kind of work. I really want to go into the book, which is so rich. It is full of so much research, so much information, a collecting of everything that's happened over the last, I'd say, 50 years in the evolution of not just psychotherapy, but even medicine. We're just beginning to reframe how injury, trauma, and life experience molds people. Life experience, even prenatally.
Right.
Resilience is becoming the new buzzword. Sadly, what happened to mindfulness 10 years ago is probably going to happen to resilience. And I'm afraid it's also going to happen to somatic therapy as well.
Yes.
Because there's so much richness here that you could more specifically say for you and Steve, what is the relationship of nurturance and resilience that you're getting at with this book?
We kind of thought about this book a little bit like a textbook for the people who did this training, because it is true that we have all these threads. I sort of think of myself as like a magpie, as I've collected all these treasures from all these different places. And that's how the experimentation has had to work with clients to come to solutions. So that information from the adverse childhood experience study, but also some information from gastroenterology or wherever we have little snippets that say, here's how we can understand this whole idea of both trauma and resilience. One of the really consistent pieces that relate nurturing and resilience together is how critical it is to have our resilience nurtured. Some of us are really fortunate that we are born seemingly inherently more resilient than other people. But we also know that even in the face of adversity, if someone is literally nurturing you, you are feeling loved and cared for. And the really big common theme is safety. That you have a consistent access of a sufficient experience of safety, that you have times to rest down and not be on alert for danger. Those are the critical elements that actually support multiple level of resilience. One of the things that's beginning to happen now is the cross-pollination between the different lines of study of resilience, because there's been these sort of two relatively separate lines of inquiry. One was about physical resilience, which really is typically done in relation to aging. How do we make people more physically, physiologically resilient? And then on the other side is the study of psychological resilience. How do we make children and adults more able to respond to their environment in healthy ways, recover from challenges? Well, the really interesting thing is they cross over. So someone who meets the markers of psychological resilience heals wounds more quickly and recovers from diseases more quickly. People who physically recover perceive themselves as being more resilient in the way we would measure it psychologically and emotionally. How is it so that we can have both physical and psychological resilience being in the same place? The single factor that makes the biggest difference for children to become resilient is at least one adult who is on their side. Someone that they have a loving relationship with, they feel supported by, they feel seen by them. They can go to them for help. They're encouraged as they grow older and they're out in the world. They're given positive feedback about their skillfulness. And literally they feel that sense of nurturing and support. It makes all the difference. Even a child experiencing severe adversity, having access, it could be a teacher. It doesn't even have to be a family member. It could be a sibling, could be a teacher, it could be the parents of their friend that they hang out at that house next door a certain number of hours each day. The nurturing process is a piece of what develops resilience for us. The first part of the book is about when that doesn't happen. As care providers, that's part of what we're doing is we're often working with the people where it was absent, and we need to understand the impact. So part of the book is about, well, when you didn't get all those good things, there's still things to do to be helpful. We also want to know from a trauma-informed perspective, every opportunity we have, whether it's with a child or an adult, to do those things that literally nurture resilience. And those are mostly relational things like showing up for the person.
You explicated John Bowlby's work, very beautiful way that meets the mental health community where they are with John Bowlby's work, and then managed to tie in Steve Porges' work, all of the neuroscience that we know about trauma and how it changes the brain. The top down, going there first in order to bring in bottom up was perfect.
And I think necessary, because if that early piece didn't happen, then the person is more prone to the wounding that later traumas might provoke. If they've got resilience on board, then they're more likely to be able to recover from those later challenges. What we wanted to do in that very beginning is exactly what you said, is we've got those attachment pieces that are more well-known in the psychotherapy world, and not necessarily what's also going on physiologically at the same time. Porges' work is now really finding its way all over the place, not just in the trauma world. While all that good attachment stuff is happening, you're tuning the physiology. It's not only about what's happening in the relationship, it's also what's happening within our physiology on both sides of that relationship, how the parent is benefited by the connection with the child and vice versa, and how that then tunes our system to make us more or less prone to our later responses to trauma that might be less than helpful.
If you could talk a bit about interoception, exteroception, and neuroception. And I think it's important for clinicians listening to know about these three skills, because in fact, these are the skills we actually learn when we learn somatic psychotherapy, how to use that much more appropriately in the room with our patients. The way you did it in the book, you took everything we know about attachment styles from John Bowlby and Mary Main's work, and then integrated it with this knowledge about these three very important skills we need to have, but also that become very distorted and colored by traumatic experience.
We really need to understand the influence that early attachment or lack of attachment, that early access to safety or lack of access to safety has on our physiology. Because it's easy to think that these systems just develop and then we can rely on them. And the way I'm often saying it to my client is, given that early context, you are no longer a reliable witness to your own experience. So for me to rely on your self-report about things is actually a mistake, because those systems get really altered by those early experiences. Neuroception, which is Porges' language that he uses for this sort of sorting that we do between threat and safety. It's made up of multiple systems. It's not a single system. It's the word he used to say all of these different systems contribute to that. It's the way we process things in certain parts of our brain. It's the way our perception of the outside environment, which is what exteroception is, how we see and hear things outside of us and make meaning about them. interoception, which is the things that we make meaning about that we consider primarily inside the body, but I'll talk in a moment about how that's not always 100% true. We put all these things together and then we make assessments about safety and lack of safety based on the combination of our past experiences and our current perceptions. So if our past experiences have been organized around trauma, our meaning making of these apparent neutral perceptions is going to be quite different. We have more and more research that shows this. One of the things that is used as a way for people to notice their internal experience is the monitoring of their heart rate, because it's something that you could measure from the outside and you could ask the person to notice it and kind of compare notes and say, are they being accurate in it? We used to think, oh, the better the person is at monitoring their own heart, the healthier they are with their interoception. Well, now we know that people who are extremely good at monitoring interoception, there's actually an affiliation with anxiety disorders. Maybe it might be when someone is obsessively able to notice every little thing that's going on inside, they may be doing that because what's going on inside feels dangerous to them and makes them feel anxious, or maybe fuels some existing experience of anxiety because now, what is that thing that I just felt? Does that mean I'm going to die? Does that mean that something bad is happening? If I've grown up in an environment where there's a lot of external danger, and then I'm out walking in a garden, I might be listening for the crack of a twig and indicators that say I might be at risk. So I'm walking through the garden feeling unsafe and listening all the time for the danger signs. Alternatively, if someone is raised in an environment where the external environment is relatively safe, I might be walking through that same garden saying, oh, listen to the bird songs, and isn't that really lovely? I'm having a safety experience in the same environment, and that's really based on my past history of how I've interpreted those signals from that exteroceptive system. Same on the inside. How have I learned or not learned? Because interoception develops in the context of relationship. We're comparing notes with our caregivers. So num, 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 aren't we enjoying our food? And oh, this is so yummy, and we're liking it together, and we're feeling bonded and sharing this nice experience. I learn, oh, this taste could be that. Or I learn, well, I don't like it, but this person likes it. So it means it's not dangerous, it's just a preference. Well, if I don't have that way to compare notes, the assessments and the meaning I might be making of those internal experiences could be more along the lines of danger. If I don't like it, it's dangerous. Now I don't like anything that makes me feel this quality of excitation. One of the main things that our caregivers are supposed to do with us, they're supposed to help us differentiate between threat and excitation. One thing is fun, but not dangerous. Another thing gives you the same kind of physiology, but you should worry about it. If I didn't have someone helping me separate that out, when I get excited, I might think something dangerous and bad is happening. Those all together then make up that neuroceptive system that helps me make decisions about, is this a threat or am I safe? My brain is literally sorting that information. There's this pre-sorting that's happening that's inclining me to move along a certain track. For future reference, this thing here is unsafe. So if I feel anything like this, I should decide it's unsafe. We might have these huge categories now that equal I'm not safe. And we might have a lot of stuff in those categories that doesn't really belong there. Now we can't be excited about the upcoming birthday party or my trip to wherever, because when I get excited, I feel unsafe. And now it's actually terrifying to me to consider the birthday party.
Clearly, unhealthy neuroception makes it difficult to differentiate between safety and threat. And then you have a physiology that is titrated toward stress and hypervigilance as its default.
That's right.
And we could also say some of the research shows that even a parent who isn't aware that their own physiology is like that, and the baby is co-regulating to a physiology that is set up like that, that is a generational transfer, even from a parent who believes that they're completely loving. This is, I think, one of the reasons why sometimes we hear from our patients, no, I had a great childhood. Well, yeah.
That's right. So worried parents tend to make worried babies without knowing I'm doing it. I think I'm actually being protective of my child. but I'm now a kind of a version of a helicopter parent where I'm just hovering all the time with my worried sense about what could be dangerous. And I'm communicating both in my behaviors, but also in my own physiology, especially with skin to skin contact. And really, when we're really young, how much of my activity is tuned to the worry. So when I move up into that sympathetic arousal system, the excitation system, am I doing that because I'm having fun? Or am I doing that looking at a parent's face that looks worried and is concerned, is trying to stop the activity because you could get hurt? My excitation system is very strongly linked to what we might call my worry system. So when I get excited, there's something to worry about. Now I've got so many things in my environment that I have to be careful of. And I'm constantly referring back to this parent who has this hypervigilance and anxiety that is continuing to give me that feedback. And honestly, when everybody around you is like that, you don't have a way to question it.
You know, you also cite mounting evidence on the other side of the spectrum, linking severe childhood trauma with later severe mental health diagnoses, such as schizophrenia and severe depression. And as we've been mentioning, the ACE studies showed correlation between adult physical illnesses and childhood trauma. With all this evidence, I'm curious, why are we still having to defend the existence and negative impacts of developmental trauma?
I don't know. It's a little bit beyond me. We have very, very skilled researchers, skilled clinicians, articulate advocates. There are people paying attention. Big systems aren't really yet taking in the information. And I don't know if it's more about that. Is it just so much that have to change? The researchers from the Adverse Childhood Experience Study have been feeling the same kind of thing. What more data do we need to tell us there are these correlations? There's certain systems within bigger organizations that are making these changes and are doing things like we are no longer using that vocabulary of borderline narcissistic. We're going to be talking about untreated developmental trauma, and this is a side effect of untreated developmental trauma. In the autism community, we're starting to see more movement in that direction to say maybe this isn't one big bundled thing. Maybe we have some people where these are the symptoms of developmental trauma, and they just look the same as someone who has perhaps an organic disorder. I can certainly say from the body care side of things, that's where many of us are moving if we've studied trauma. Some people that maybe have genetic predispositions, doesn't have anything to do with trauma. Maybe we have people where it's epigenetics, it's transgenerational trauma. They have no trauma in their history, but their ancestors do, and now they're unfortunately manifesting that. And then we have people, there's a direct line from their own developmental trauma into these symptoms. They aren't all the same. The symptoms could look very similar, but different sources, and maybe we don't know fully yet different treatment that has to happen. So we need to stop bundling them all into the same place. And I don't see that we're there yet in terms of what we categorize as mental health issues. Is everything that we were thinking as personality disorder really untreated trauma? What I advocate is for people to share it every place they can. So when you go to your own physician, you ask them, do you know about the Adverse Childhood Experience Study? And if not, you should, because it should be part of our conversation. When you're talking to your therapist, certainly my clients are doing that. And so getting our clients educated helps them be advocates for themselves. It's the reason we wanted to have all that research in the book. We found the studies that say this is important.
Which I love, because I don't have to put all the studies in the show notes. I just have to put the link to your book.
We wanted to really go back to the original research because we knew that it's going to be professionals looking at this, and they need to go and get the information that will really tell them as a professional the value of this. We want to have the book be technical enough, and you can see that we've backed it up with the research.
Getting back to the material in the book, I just want to read a quote from the book. You write, in infant and childhood years, our brains are not fully developed, and we are unable to acquire and assimilate memories in a narrative fashion the way we can as adults. We are little somatic beings responding to our experiences in a non-cognitive way. Do you think this is why somatic psychotherapy is maybe a better methodology for healing trauma that occurred in early developmental stages than traditional talk therapy?
Absolutely. And it's also that bridge across to advocating for the inclusion of touch. Because in those early weeks and months of life, our primary form of information is coming in through that tactile and somatic system and through our hearing with the cooing, the coo language, being awash in our internal and external environment. In our youngest weeks and months of life, inside and outside are not different things. We are not developmentally able to differentiate things that happened inside of us versus things that happened outside of us. We slowly learn, oh, this person is not me, and I can call them over to me and get them to respond to me. And then when I get even more mature, I can manipulate my environment and reach out and touch things and bring them to me and put them in my mouth. But in those earliest times, there is not that me and not me. And to a certain degree, even up to 2 and 3 years old, we're really not holding our experiences in that more linear fashion. Our brains aren't causing us to require that as a way to get about our business. We're here in this sort of unformed quality where time doesn't yet have the same sense of moving in a direction, with our somatic selves kind of driving. Mm-hmm. So then to expect even an adolescent, but certainly as an adult, to have a narrative about that, they will, but it'll be basically a made-up story to try to find a place to park those experiences that they don't actually have, in a way, cognitive access to. It's not going to be in there as a memory per se. It's going to be in there as an accumulated body response, habit, sort of a sense of. That's often the language that's used both for interoception, but for early experiences, a sense of something, like a vague impression. That isn't really easy to access with what I term verbal narrative, because the structure of language requires you put something before something else. And it's actually difficult in language to express something that was happening all at the same time. That's our somatic experience. It's all happening simultaneously, and then we're having responses to that.
So you're saying that what you call somatic narratives are memories being laid down, not just in the autonomic nervous system, but also maybe in the tissues, the organs. It's not verbal. You term this overall trauma map.
Right, if it's related to trauma.
I mean, obviously, everything we learn at that stage of life is laid down in this way. It's not just trauma experience. But for experiences that might later color our psychological and behavioral responses, as well as belief systems about ourselves, others, in the external environment, I think this is the critical piece for mental health professionals to understand. This is a narrative that spans the organism. And you can't just come at it from a verbal and cognitive, conceptual narrative.
And it's an important narrative.
Yes.
That's the other piece that can come in is, as a culture, I believe we overvalue what I think is the cortical narrative. It's not just that it's verbal. It's that it's verbal related to cortical experience. That gives it a certain framework that we then begin to think is the most important framework. I don't care if the client is trying to struggle with a verbal narrative to express that underlying experience, and they're saying things like, well, it's kind of like this, and then if you imagine this thing, it would be a little bit like that. And they're certainly using language to try to point me in the direction of their experience. But what they're doing is a translation from that internal wash of it's a little this and it's a little that, and I don't quite know how to say it, but I'm doing my best to make a story about it. But we do have to understand it is a translation, and we will be somewhat inaccurate or a lot inaccurate as we're doing that translation. And so if we as the clinician can join them in the somatic attention, whether through touch or whether through a resonant field or some sense of observation that includes not just what they're saying, but what their breath does while they're saying it, and what does their posture do, and how do they manage their bracing or relaxation and their relationship to gravity and those hidden little micro movements. All of those things are a part of the somatic psychotherapy approach, where we're really observing the body cues that are coming in to fill in the narrative while they're struggling to put into language these things that are not cortical in the way they're being held. They might be limbic. They're impressions of emotional states and responses and preferences. But in trauma, they're often what I call really brain stemmy. They're really like survival oriented. And we're a little bit inclined to make big chunky meaning of those things. Like I was talking about before, it was really dangerous. It was really bad. And then you hear later that actually there were some good things about it, and there were some things that weren't dangerous, and there was someone who was helpful. But because it was survival driven, we put a higher value on the survival oriented pieces of the narrative. And maybe embedded in there is actually someone did step up to help us, and someone did try to nurture us and did try to comfort us. But we were so beyond our ability at that point to find safety, we didn't notice it. Our narrative that we may have created that said, no one was ever there for me, turns out not actually to be true. But we don't have a way to get at it when we're coming at it with our cortex. That narrative is going to be persistent until we can drop down into the underneath wash of the somatic narrative of it.
It's so great that you brought up survival, because pretty much anybody who's been trained in the mental health world will say we're adaptable animals and we meet challenge and we survive. Two things in the book that I think are so informative for mental health professionals: the window of tolerance idea, the faux window. So I'd love for you to talk a little bit about that. And then the other thing is this sense of somatic shame and how it informs identity trauma and how people grasp at both of those things for a sense of who they are. I think these are two stumbling blocks that really get in the way of most psychotherapeutic work. And many therapists, no matter what they try, they have a very difficult time either conceiving of why it's there or working with it when it is there.
That idea of the faux window actually developed in the classroom context as we were teaching, because both Steve Terrell and I have this experience with clients that the symptoms sometimes are hiding this thing underneath that they're actually trying to get to, which is that regulation piece. And our whole approach would be a regulation-informed approach. What we're looking at is getting regulation back on board that was either disrupted by trauma or was never there for the reasons that you and I have already talked about. They didn't get that nurturing, or they had enough of a big hit to it, like repeated hospitalizations or something like that, that even though their caregivers were doing their best job of nurturing, the influences were so severe on the other side that the nurturing couldn't really take hold. One of the things that can happen is that, as with adult clients particularly, but you'll see it with children as well, we will figure out whatever the strategies are that dampen down those chronic stress responses that go with that survival physiology, which is not meant to be operating 24 hours a day. And so we will develop strategies to keep things on an even keel. Then that's where that difference between the genuine window of tolerance, which is regulation in the sense that we have the capacity to have a response to something, and then naturally come out of our response into settled physiology. Or we get so afraid, we sort of freeze and go into that kind of collapse, freeze physiology, but it has a short duration. We come out of it naturally. We come back to normal state of function in the sense that we are in good relationship with our environment. We're not hyper or hypo responding. So that's the window of tolerance, is we have this sort of ideal zone where we can follow the rise and fall of our response system. The idea of the faux window developed when both Steve and I were recognizing with many of our clients in our client population, which is going to be mostly people with developmental trauma, for me, not always, with Steve, 100%, what looks like their window of tolerance actually isn't. Their systems have been outside of their window of tolerance maybe from day one, or 6 months, or 2 years old, or for so long now. The window of tolerance is a purely theoretical model. There is actually no such thing as genuine regulation. They will always be using adaptive strategies to manage their physiology because it's already outside of its normal range. Even when they're looking pretty calm and okay, I use the metaphor of the duck on the pond. They look like they're smoothly going along, but you look underneath and little feet are going paddling madly to give the impression of that even keel. Now, how that manifests will vary from person to person. It could be physiological strategies. They're taking the hit in their immune system. They have chronic high blood pressure, right? Their physiology is in there just madly responding and trying to keep the lid on things to keep from blowing up into bigger symptoms. But you could equally see behaviors using food as a way to dampen their anxiety, or cutting, or alternating between big rages and collapse into depression. The management strategies, the term we use in the book is defensive accommodations. The things we do to create a false window of tolerance will be applied. The better we are at that, the more it fools us and the clinician. So then as the clinician, I see this person say, hey, they're looking pretty good. I'm not seeing these big symptoms and responses. And so we misinterpret and we think, here's a client that's got a good, healthy window of tolerance. And so I can then do whatever interventions based on that assumption. So then I might overstimulate the person because I think they're ready for some big chunk of work. Now we're going to get in there and delve into the history of their sexual abuse. And then you blow up your clients. Because you mistakenly interpreted their faux window as their genuine capacity for regulation. You're presuming the capacity for regulation and their ability to kind of get back within their window of tolerance. And they don't, because they're already outside of their window of tolerance. And then by stressing them further, by asking them to talk about difficult things or remember difficult things or track sensations that are hard for them or whatever methods you're using, they so far exceed not even the window of tolerance, but they're outside of even their faux window. And they have underneath it, which is why they have the faux window in the first place, an out of control physiology. Underneath everything, there is dysregulation. For this person, basically, there is no actual regulation on board. And then you will be wonderfully surprised by the really big symptoms that will show up with a client that was kind of looking okay up until that point.
I never had the language faux window. I saw it. This is so great because sometimes I'm doing the first session and it's going along and I will do something to provoke to see whether or not the system goes into high activation or whether it completely collapses so that I get a sense of if there's something underneath. Because sometimes people will feign some kind of fineness, but they're coming for something.
And what's true with many clients is they don't actually know that these are management strategies. Or they know kind of that they are, but it's like, well, what choice do I have? And so often what I'm saying to them is, I know this is a foreign concept, but what we'd like to get to is to have enough regulation on board. There's nothing left to manage. But if you've spent your entire life managing anxiety or physical symptoms, might be pain syndromes or something, that is like a foreign concept. It's like, I've always had to manage this. I will always have to manage it. That's not what I'm hoping for here. I'm hoping you would help me with these other things. So I'm trying to back up to say, if we come in with regulation underneath, some of those things that you think are just a given might actually be no longer necessary. As the practitioner, we're having to kind of scramble back inside the genuine window of tolerance, which means our interventions may have to be painstakingly slow and small, which could feel frustrating for the client. So the education piece is important. The management strategies are the substitute for regulation. As a mental health care provider, you're going to be looking at it behaviorally and the way they're thinking about things and how they behave in relationships and how they think about themselves and how they feel about themselves. I don't really care where the regulation shows up. Sometimes what I can tell is, oh, they're thinking different. They don't have the black and white thinking that they had before. They're having more nuance and they're more able to bring a little bit of problem solving or critical thinking to their responses. So as a therapist, you may be hearing that their physical systems are beginning to regulate first. Yes. So you may hear symptom reduction in things like migraines or pain or other somatic physical symptoms that in a way kind of sound like they're not your job, but you want to be listening for them to be changing when better regulation is coming on board, because honestly, that'll be the precursor. Soon they're going to have better affect regulation, and soon you're going to be able to use it for the work that you're doing with them. Then you can bring your bigger interventions. You can do what I call cleaning out the back of the closet. You can get to the traumas. You can get to the thing they came in for that said, this is what I want to be different in my life. Now you can start doing that work because you've got the tool pouch more full of the capacity that the client needs for regulation and skillfulness, capacity to be with uncomfortable sensations. They're not going to like how they feel, but they can be with that and know that I can sit with this because something's going to be different soon.
I'm very committed to your goal of completely decimating the idea that there's any separation between the mental, emotional, cognitive, affective symptoms, and physical symptoms. One of the very generous things that you and Steve did toward the end of the book is you actually laid out a set of treatment strategies for working with early trauma. Do you think you could just share one or two of the treatment strategies that you think are most critical for people in the mental health profession to learn first and impart to their patients for co-regulation?
What I'd like to do is just back up a little bit to get to the other question you asked about somatic shame.
Oh, okay.
And then we can come back. The somatic shame piece is a really important one for any kind of trauma. And that term, the term somatic shame and identity trauma, are terms that David DeRosenroll, who's one of the SE faculty in Canada, is a counselor educator, works a lot with the First Nations community in British Columbia. Those terms are, I think, really important terms in relationship to certain kinds of trauma that kick us into a different track, so to speak. Developmental trauma does that. Identity trauma has embedded in it the genetics. In many, many cultures, the generations that have been exposed to trauma are multiple. Our own sense of community, ancestry has embedded in it this cultural shame, that linking between that history of trauma and the feeling of shame of being out of control of our responses, that it must be me that's the problem. And that's the thing with somatic shame, not that it's really different than any other form of shame. Shame picks us up and kind of takes control, even though our cortex is saying, this is ridiculous. There's no reason for me to feel this way. Somatic shame permeates all of our cells, and we don't feel like there's anything we can do about it. It's a very common affiliation with developmental trauma. Being out of control of ourselves can feel shaming for people, even when we have this mature, healthy part of ourselves that says, I shouldn't feel this way. And then the very fact that we keep feeling that way causes us a feeling of more shame. Some people use shame as the catch-all term. You'll hear people say there's no such thing as a good level of shame. We might then want to differentiate between shame and remorse or regret. You could have shame that would fall in a healthy category. Porges talks about it's pro-social. It's the way we learn our social group's rules that tell us, here's how we are a good citizen in our community. And when I break those rules that I'm beginning to internalize to say I have value, I feel shame. Or as I'm learning those rules, I have these active corrections from my community that says, don't do that. Like violence towards another person would be a common one. Don't hit your brother or whatever. And so I feel this contraction of shame, and everything's going well. The caregiver then comes back into relationship with us and says, oh, sweetie, I just need you to know not to do that. So we have this repair that's embedded in it. And we have this cycle that is healthy that says, I feel this shame. People tell me it's the behavior and not me.
Exactly.
That deep identity trauma, somatic shame is where we get confused, either because people are actively attempting to confuse us and manipulate us, or because we have this shame feeling that's passed down through the generations. And our understanding is, I am the shameful thing. I don't deserve love. It's not my behavior. There isn't a separation between the thing that is a shame and myself. Healthy shame is that differentiation between self and behavior. And that unhealthy shame says, it's me. To have the shame be different, I have to be different. Shame is affiliated with the inhibitory physiology. Going back to faux window, we accidentally figure out that shame slows down our physiology. And so one of the management strategies that we may get forced into is, as we slow down, we feel shame. It becomes the way that we stop something that feels like it could become dangerous. And so you'll get statements like, people would be harmed by knowing who I really am. Coming up into my full bloom of self is actually going to be harmful to other people. Is that making sense?
It makes so much sense. I like to say to my patients, shame as an emotion is prosocial because it connects us to a community. It's not isolating. It's actually connective. Toxic shame or somatic shame, as you're describing it, is just like guilt. It's just a recursive set of thoughts that go nowhere, focused on, I am a terrible person.
Right.
It's actually thoughts. It's not, neither of these things are actually emotion in a sense. They're just identity. It's a way of thinking about oneself. Therapists who don't make this distinction, they're actually making it impossible for their patients to have healthy feeling of shame, which is very important because it says, I'm human too. I'm imperfect.
Right.
I'm human. And my humanness, sometimes I do things that may cause me to feel a little embarrassed. And it doesn't mean that everything is broken and I'm terrible. And this, to me, is the hallmark of what old psychology used to call personality disorders, but which you and I will agree are these deeper underlying distortions in the psyche and the physical system of the patient, telling them a story about themselves that has nothing to do with the actuality of who they are as a being, an actual human being.
Healthy shame has a remedy. You apologize, you
Absolutely.
make restitution. There's a way out of it. Talk about nurturing resilience. Being able to have that experience is going to build our sense of capacity. And so if we're always linking that idea of shame to something we should never feel. So as a therapist, if we're putting ourselves in that bind, I get this all the time from psychotherapists who are doing consultations around the somatic pieces of this. I don't want my clients to feel shame, but they came in the door feeling it. So if you're like hobbling yourself that you can't do anything that's going to make them feel shame, how are you going to help them heal from shame?
Exactly.
And I'm coming at it somatically. It's like, what does it feel like touching into that quality? And how is it when someone welcomes you back out of it and we can meet each other again somatically with me welcoming you back into yourself?
Yes.
So
this is an extremely important discussion, especially for people who do not work somatically, because honestly, this is part of the bridge. Our profession for a long time has not been connective. What can I say?
right.
The entire body has been left out. And so this is an effort to try to make psychology organismic rather than it's just a brain and it's just a bunch of responses from that brain. This really doesn't work for anyone.
That's right. And that goes back to the other question that you asked about what are the kind of steps. And that's also why we put that section in the book, because ironically, the more complex the person's symptoms are, in a way, the simpler the treatment plan gets. And we wanted to articulate that one as we did in the book, because there is a kind of an arc that is the typical treatment that needs to happen, whether you're coming from a mental health side of things or a physical care side, doesn't really matter. In the context of trauma, in the absence of regulation, and the absence of a window of tolerance, it has some movement in it, some capacity to have a response of activation or a little bit going to that freeze, collapse side of it, and then recover from it. If you don't have that on board, almost everything else you do is either going to be wasted because it can't be taken up, or you're going to then have the aftermath of dealing with the symptoms that got provoked as a result of the intervention. And you're going to get maybe a fifth of the time or less that you're actually making progress. And the rest of the time you're cleaning up the mess that happened because they over-responded to your intervention. The bottom line is that first thing from our perspective, really simple interventions, getting the person back inside their window of tolerance, developing a window of tolerance if they don't have one, and getting them back inside of it, taking the stressors off. I'm very often saying to people, it's about what you're taking away, not what you're adding. You don't need to add more challenge for this person. They're challenged getting up in the morning. So you're helping them have less challenge so that they have some possibility to get back inside their window of tolerance. Once you've got that on board, and with some clients, that can be a year or two, just really like taking the strain out and focusing on regulation, then you can get fancy because their system starts to simplify. They're not having such big reactions in their symptoms. They're not as uncontained and uncontrolled in their responses. They know themselves better as a physiological being, so they're more familiar with their sensations. Hopefully, you've supported them in having more accurate interoception. They're making a little bit more accurate meaning about their experiences, so they are a more reliable witness to their own experience. Now you pull out all your fancy tools and you get in there and do the work at hand, whatever that might be, working with the themes that have been problematic for their life, working with specific symptoms. And then the really interesting thing to me is what follows that is you end up going back to the simple interventions because you have a client that has so much capacity now that your tiniest little gentle intervention is taken up and absorbed and made their own. And you might do this little exquisite piece of work and then spend weeks or months of them extracting every little benefit out of that one simple suggestion or one simple bit of questioning or however it showed up for them. They've just got so much ease in their system now, they can take the work and run with it. That regulation phase is not a few weeks or even a few months with people with severe early trauma. I'm really looking at a year or two. It doesn't mean we're never doing anything else. We're also addressing problems and coaching and helping, and we're certainly making progress as we can everywhere else that we possibly can. The benefit is by the time we get regulation on board, a bunch of the other stuff we thought we had to do, we don't have to do anymore.
Some of the clinicians listening right now might be thinking, there's no way I can have that many sessions with patients, either because of health insurance reasons or because they work in systems. And I feel like it's really important as somebody who's been trained by you to say to them, the skills you learn can be used short term as well. You may not be able to do this kind of deep unwinding and healing work with a patient. On the other hand, you will give them so much more in the number of sessions you actually have with them.
That's true. Our system does not support good treatment for people with complex symptoms. To a certain degree, we have to set that category of client aside in that we do the best we can. And regulation work, in my opinion, will often have the best effect on them for the shortest number of sessions we might have available to give them. I would tend to want to do regulation work. It's going to give them a tool that they can then use when they no longer have access to you, or they don't until the next year when their insurance re-ups and they can come back again. So what we know about regulation and nurturing of resilience is some is better than none.
I cannot say enough. Buy this book. That's all I have to say, because there's so much here that will really explain the direction in which psychotherapy is going. You're at the head of the wave. Thank God you're at the head of the wave, because there could have been people with so much less knowledge at the head of the wave. And I encourage everyone to buy this book.
Thank you.
If people really want to come and train with you, which I also highly encourage people to do, how do they do that?
My website, which is somaticpractice.net, or Stephen Terrell's website, which is austinattach.com. Either one will list the various workshops that we each have.
Are you just solely doing this now? Or are you no longer doing advanced year?
I am still teaching the advanced SE training. I have a program next year in Canada, is the only one that I'm doing. And we're scheduling now for 2020. So yes, I am still teaching in the advanced year for somatic experiencing.
Well, I can say it's worth buying a ticket to Canada. Literally, I cannot imagine having taken my third year of SE with anyone else, particularly since that second module is all touch.
Yes.
Who better? My friend Carol Marks and I were together over the last few days. And at one point, we both looked at each other and we said, Kathy Kain was the best thing that ever happened to Pierre Levine.
Oh, that's very sweet to say.
So before we end, is there anything else you want people to know or hear that maybe we haven't talked about?
I think we just kind of covered the waterfront, actually.
Well, I can't thank you enough, Kathy.
Thanks for listening to today's show. The Groundless Ground podcast is now available on iTunes, Google Play, and Stitcher. To find out more about this episode, see a list of upcoming guests, or get in touch, visit groundlessground.com. Now let's dedicate our efforts to the healing of our planet and all its inhabitants. See you next time on the Groundless Ground.